Hi, everyone. So something we commonly don't talk about in a CPR class is basically what if we actually when do we stop CPR? What if CPR actually works? So that's something I know we don't cover a lot in CPR classes, so I wanted to put that in this add-on class. So one thing I'll start with is uh, the survival rates for CPR. So just to give you an idea, basically overall the survival rate of CPR is about 9%. However, when CPR is performed on a witnessed cardiac arrest, meaning somebody saw the person go down and immediately started chest compressions, those survival rates come up to about 30%. So about one third of the time, if somebody starts CPR right away, you might actually get a survival. So that happens enough that we probably should talk about it. So we're going to talk about post-resuscitation care, in other words, if CPR works, and we're also going to talk about ventricular assist devices. So recognition of ROSC. So first of all, what does ROSC stand for? Return of spontaneous circulation. In other words, spontaneous means on your own. Circulation would be blood flow. This is just a fancy way of saying they got a pulse back. Their heart started beating on its own, and we call that ROSC. When do you stop CPR? If you remember during your CPR training, when we first arrive on scene, we check that patient's carotid pulse and we check for breathing to determine, if they're lifeless and we need to start CPR. But we never really talk about checking the pulse again. That's because you never stop CPR to check a pulse. Basically, if somebody have higher training in ALS and things like that, they'll sometimes use a 12 lead and they'll have you stop to check things like that. But as a BLS provider, we don't stop CPR to check a pulse unless we see obvious signs of life. And so, uh, you know, like I said, if there's ALS and they see an organized rhythm, they might have you do that. As an EMT, we can't do that. So if they open their eyes, start moving their hands, start to move around, try to talk to you, things that they're obviously alive, that's the only time we stop CPR to recheck a pulse. Otherwise, we just keep going with those chest compressions. Be the same thing if they start to spontaneously breathe on their own. Now, be sure you don't get fooled by those agonal respirations, which are basically just a muscle spasm of the breathing muscles that sometimes happen as the brain sends a signal to those muscles of breathing after the heart stops beating. But if they're truly breathing on their own, opening their eyes, trying to sit up, trying to talk to you, moving their hands, blinking, things like that, that's when we'll stop CPR. Otherwise, we just keep going. Okay. Optimizing ventilation and oxygenation. So again, we're assuming that we're doing our chest compressions and they start moving or they open their eyes and we stop. So now what are our goals? Well, we want to keep their oxygen saturation to at least 94%. So it's not going to be uncommon if a patient in cardiac arrest reaches ROSC, if we achieve ROSC, they're probably not going to be doing so hot. They're barely alive. Their oxygen saturation is going to be very low. So at a minimum, you're going to need a non-rebreather going at 15 liters per minute, but more likely you're actually going to need a BVM attached to high flow oxygen to help them breathe as they kind of try to catch up on these lower levels of oxygen. So get a pulse oximeter on them, keep that O2 sat at 94%. Now, more is not better. We don't want to blast them with oxygen to get them up above 94%. We'll talk more about that and why here. So you do want to avoid excessive ventilation, and this would apply during CPR, after you've achieved ROSC, really on any patient that you're using a BVM on. You want to avoid excessive ventilation. And by that, we mean for an adult, you want to give a breath every 5 to 6 seconds, or for a child, every 2 to 3 seconds. The reasoning for this is because if you give too many breaths, or if you give too much of a breath, so again, it's every 5 to 6 seconds, but we only want to squeeze that bag until we see chest rise. If you see chest rise and then you continue squeezing the bag and you put extra air into the lungs, that air is leaking out into the thoracic cavity, and now it's starting to push on the heart. Remember that the heart needs to be able to relax and refill with blood, and then our chest compressions are going to push it to squeeze the blood out. Or if the person's heart's beating on their own, same concept. It needs to relax to fill with blood, and then the heart will beat or squeeze to squeeze the blood out. So if you get too much air pressure built up in that thoracic cavity, it's going to reduce cardiac output. Remember, cardiac output is the amount of blood that your heart pumps in 1 minute. In other words, if the heart's under pressure, it's not going to pump enough as much blood. So by giving too many breaths or too much air with each breath or giving those breaths too often, you're actually making it more difficult for the heart to function as it's intended. So the heart's not able to pump blood because of that extra air in the chest. So you want to be really careful with your ventilation. The other thing is that if we get too much oxygen in the blood, if our oxygen saturation gets up above 94%, this can decrease cerebral blood flow. Remember, the cerebral, that means brain. So we can actually have less blood going to the brain if we have more oxygen. I know back in the olden days, it used to be some oxygen is good, more is better, even more is even more better, right? Just more and more oxygen was great. But science changes things. We've now learned that there's something called oxygen toxicity. If we get their oxygen saturation too high, it actually starts to damage their red blood cells. Those damaged red blood cells cause all sorts of problems. Our bodies are smart and they have a lot of protective mechanisms. So one of the things is that if our body detects high, like way too high of oxygen saturation, our carotid arteries actually constrict and reduce the amount of blood that's going to the brain to protect the brain tissue. So by giving somebody more oxygen, you're actually causing their brain tissue, the most important tissue, to actually get less oxygen. So many, many reasons we don't want to overventilate or over-oxygenate our patient. Okay, hemodynamic instability. What in the heck does that mean? Well, that's just a fancy way of saying our S word in EMS, which is shock. That means shock. When somebody comes out of a cardiac arrest and they're in ROSC, they are going to be in shock. Their body is just starting to come back. Their heart is starting to pump blood on its own, but it's going to take some time to catch up. And right now, their body is just going to be focusing on keeping those vital organs alive. So in the meantime, we need to monitor their vital signs. Of course, we need to ensure vascular access so we can get IVs going to start to get that blood pressure back up. Now, as an EMT, we're not going to start IVs, but we're going to prepare our patient for it. We're going to prepare the supplies, and then we're going to monitor those IVs after they're in place. So you're going to play a big role in this. You know, you're going to talk to the patient, let them know, hey, we're going to start an IV. We're going to give you some fluid. This is going to help get your heart rate up, get your blood pressure up. Then we will, get the supplies ready, and then we will monitor them to make sure that's not leaking or doesn't get pulled out, make sure it's not irritating the patient, all those kind of things. Okay, we're also going to monitor and manage cardiac hemodynamics. In other words, that just means blood flow to the heart. And what can we do to manage this? We can just treat for shock, right? Managing hemodynamics means treat for shock. So we can make sure the patient has enough oxygen, keeping that oxygen saturation at 94%, cover them with a blanket to keep them warm, make sure they're laying supine and we're talking to them to keep them calm. And we're, getting ALS on scene if they're not already there and transporting our patient to the hospital so they can get a higher level of care. One thing that might be done at the hospital is therapeutic induced hypothermia. There's a whole video on this. I can, if you want access to it, you can Google it or look it up on YouTube. You can also email me and I can send it to you. But there is a whole video on this. We're not going to watch the whole video, but because it's outside of our scope. But just be aware that if you take the patient to certain hospitals, they will be able to basically induce hypothermia to give the body time to catch up. We know when somebody's hypothermic that their organs demand less oxygen and nutrients to basically stay alive. So we can cool them down, not we, medical professionals higher trained than us, doctors can, and only specific doctors can cool them down to cool their core body temperature, basically so that their body can kind of catch up and get all those nutrients and oxygen they need. And it'll keep all their organs a lot more preserved while they get out of that state of shock. This is done under very specific guidelines. They're monitoring the core body temperature at all times. They're lowering the body temperature very slowly and very specifically, and then raising their body temperature back up. So please do not throw your cardiac arrest patient who received ROSC out in the snowbank. That's not what we're doing. It's in a lab under monitored conditions. So not anything we can do, especially not in near future as EMTs or even as paramedics in the field. But it is something that we need to keep in mind. It's important to get them to the hospital because they can do more things there that we would just never even think of in the field. Ventricular assist device. So what is a ventricular assist device? If you're a fan of Grey's Anatomy, you probably remember the episode about the LVAD. That was a left ventricular assist device. Those are more common, but they do make right ventricular assist devices. So let's think about what this means. A ventricle That's the exit or the pump part of your heart that pumps blood from your heart. From the right side, it pumps the blood over to the lungs. From the left side of your heart, it pumps the blood out to your body through the aorta. So it's the part of your heart that's actually pushing the blood where it needs to go. If the ventricle is not functioning correctly, sometimes patients can have this device implanted and it just assists the ventricles in pushing that blood. It'll actually take over completely if the ventricles aren't working, and it'll push that blood where it's supposed to go. So again, you can look up more videos on this. There are tons of videos on YouTube about ventricular assist devices, but keep in mind the way these work is instead of a heart going squeeze, relax, squeeze, relax, squeeze, relax, we have this machine that's a pump that's now continuously pumping blood through the body. So really important things for you to remember is if your patient has a ventricular assist device and you need to find out if it's working, well, first of all, if they're talking to you and their skin is pink, warm, and dry, it's working. If they're kind of on the edge, going into shock, and you're not sure if it's something else or possibly the VAD, you need to listen to their chest. Use a stethoscope, auscultate their chest. Instead of hearing lub dub, lub dub, lub dub, you're going to hear a whirring sound, basically like a motor that's running, and you'll hear that blood being pushed out of the heart. If you try to check their pulse, there's a good chance they will not have a pulse. Again, it's not whoosh, whoosh, whoosh. That's what we feel when we feel the pulses. We're feeling that blood being pushed out by those ventricles. Push and then relax, push and relax. When you feel a pulse of a patient with a ventricular assist device, commonly it's a continuous pushing of blood. So you're not going to feel each wave of blood coming through those arteries. You're going to just feel it's just a continuous flow. So you might not be able to feel a pulse. Same thing with blood pressure. You probably won't be able to get one. There's some studies out there where they go into, should you do it by auscultation or should you use palpation or should you use the automatic 12 lead machine? Really, none of them are very accurate. I wouldn't really trust the numbers you get from any method, but the machines are the most accurate way of getting the blood pressure. In the hospital, they're going to use an ultrasound to get a blood pressure, the same way they do at the vet's office to get blood pressures on animals. So the family are going to be the experts, just like any other medical device we learn about. The family are going to know more about that device than anybody you'll ever come across, except for maybe the surgeon who implanted it or the person who invented it. Outside of that, the family are going to be your friends on knowing how this thing works, what to expect, what's normal for that patient, what's new today, and things like that. So I hope that helps. That's a little bit more information about cardiovascular emergencies. And if you have any questions, feel free to email me or reach out and I can send you more information. Thank you.